I will start by introducing myself because we have some new people today. And my name is Mildred Fakoya. I am a software engineer, data scientist. I am the developer of the case-based surveillance system. I develop reporting system, softwares, education, surveillance systems, and computer vision and diagnostic systems.
Good morning, everyone. I'm Andrea Williams. I'm medical technologist. I work in the lab, and I also work with the HIV unit in St. Kitts.
Good morning, everyone. My name is Akila Moore, medical statistician for St. Kitts.
Good morning, everyone. I'm Glover Williams, clinical nurse, St. Vincent.
Morning, everyone. I am Lester Guy, the NAP coordinator, Dominica, and I also participate in our IDC clinic.
Okay, next.
Good morning, everyone. I'm Dr. Stephen Adifa Jemilane. I'm a guest here. Thank you.
Good morning, Judy Nesbitt, HIV CCC, Nevis, St. Kitts and Nevis.
Okay, we have introduction in the chats. We have Kim. Sorry, what island? We also have Kevin Gregor from Dominica. We have Lennon. Can we know your island, please? Okay, Lennon is from St. Kitts. We have Luan from Dominica. And if you...
Good morning, Lujan Taveras from HIV unit from Dominica.
All right, thank you all. We are going to start now. So welcome again, everyone. In the past months, we have gone through several modules of the system. We have collected data, and we have seen how the system flows from registration up until clinical management. So we're going to review the system configuration, and I will show you how the supervisors enter the reporting dependent variables for auto-generation of reports based on the data that are collected on the system. So all program managers or IT or admin managers are to configure the system before initial use of the system. The configuration involves creation of sites, ethnicities, health districts, parishes, the list of pharmacies, the list of drugs, the list of vaccines, the list of screenings, the test modalities. All of these are the system-dependent variables that populate the drop-down menus for screenings and management. But we have the reporting-dependent variables that the system depends on to calculate or to do data analysis of the data collected. And these variables are the national census population by sex and age group, which is to be entered on the system, and all of the reporting depends on this entry. So for as many data as you have, you want to enter census population for the most, let's say for the last year or the least year on the country, on the system. So for instance, if you have data for 2010, you want to make sure you have a census population prior to 2010 or equal to 2010 on the system. If your data is just from 2022, then you want to record the last census population. What the system does is that when doing statistical analysis, it looks at the census population that is less than or equal to the selected reporting year, but not greater than the reporting year. So it's less than, but the closest less than. So if you have 2010, 2012, and you want to get reports for 2015, it will automatically use the 2012 census population because it's the highest or closest census population to the reporting year that is not higher than the reporting year. We also have dependent variables for advanced reporting. If you collect census population by census division in your country, then you will record that this is not required. But if you need to do any advanced reporting, you want to see the cluster of different disease from different divisions. Then you have the population of each census division, and then you have the data filtered by that division. Then you have economic variables, which is also used for advanced correlations. If it's not required, but if you have it, you enter it. So you want to enter the GDP, the government expenditure, the educational expenditure, and the health expenditure. And what the system uses this for is to do a correlation to see what factors affect the disease, the disease progression, or what factors affect client response or the health system. So in the event where you have a correlation between GDP and the number of new cases, let's say, for instance, number of new HIV cases, you want to see, does it have a positive correlation with the cases or a negative correlation? And those type of statistics is what you do to do some inferential statistics for decision making. This is not required, but if you have it on the system for advanced reporting, you can also put it in. We also have national bets by sex and by the sex of the clients. Sorry, we have national bets by sex of the children born. And you enter these records for as many as you have. You enter the male births, the female births, and the number of live births. Now, male and female births might not be equal to live births because we are not recording stillbirths, but we are recording just the live births. So the total male birth, including stillborn, the total female births, including stillborn, and then the total live birth. You also have national births by census division. So just as we did it with the census population, you can do it with the birth also. You want to enter the birth record based on the census division of the birth if you want that kind of advanced reporting. And this is not a required field. Yes, Lester?
Okay, so Mildred, we may be able to, for example, when you look at the census division, do it by parish or do it by health district. If, for example, when you're taking information from your general population, when you're doing an assessment, is it, if you put one of them, for example, if you just put district, will it just give you by district, or is there the possibility that you have district and parish and you can pull out from anyone if you want? Is that possible?
For now, it's not, but I can make that possible. Right?
Okay.
Yeah, but you see, in most of the island, when I looked at the records in Ireland, health districts or health divisions are sometimes different from census divisions.
Parishes, yes.
Yeah, and it looks like most census divisions are mostly the political divisions, not the how the health is divided.
Okay, so, all right. So it can stay if the health districts. It makes more sense because that's what you pull on the health district, the health information for the district. So it's okay. I was just asking.
Okay. So in the event where you want to do by census division, that's why I made this optional, is that you might have difficulties getting the census population of a particular health district because maybe the health district covers 2 or 3 census divisions and you cannot accurately separate that population. So for countries, like St. Vincent that have their census division almost the same namings with their health district, it becomes easy. But for other islands, when I went through the file submitted, it's not that separated clearly. So you will now use this census division optionally if you have your record entered this way. If not, just enter the national births by sex and ignore the census division. So we also have mortality by age group and sex. So this is where you enter you select the age group, the year of the data, the age group, the male death, female death, and total death. Now, because countries are only recording males and females, no intersex, the deaths of unknown gender or unknown biological sex here might be added to the total. So if you add male and female, it might not be equal to the total, but might be in the same range because of the added figure of those whose gender were not specified. So we have the age group from 0 to 4, 80 and over, and then the age group that is not stated. You also enter the mortality by census division and sex, which is also optional. If you have the deaths recorded by each different census division, you want to record it. If not, you can leave it blank. And then you also record the child mortality. And the child mortality is also important when we are looking at the death of exposed infants. And so the child mortality only looked as children less than 1 day to 4 years old. And you want to record the number of male deaths, female deaths, and total deaths for each of these categories of children. So I'll repeat it again. For the surveillance dependent variables, the required form or data to enter before you use the system are national census population by sex and age group, national births by sex, mortality by age group and sex, and child mortality. All of the others, national census population by division is optional, economic variables is optional, mortality by census division is optional. If you have them, you enter, but if not, you can just go with what is required. Now, this is a one-time entry, except if you have new census population in some years to come, then you want to enter the new information. But once you enter the information for this year, you might likely not have any change figure in the next 5-10 years. But if you have a change figure, then you always come back here to enter new census population. So once this configuration is done, the system is ready to start data analysis when the labs and the testing sites collect information about the clients and the patients. So I'm going to log out and I'm going to log into the surveillance. Now for the reporting, I have grouped this reporting into different categories. We have the screenings reporting, then we have the management reporting, and then we have other reports that are just a calculation of what targets are. So today we are going to look at the screenings and prevention and control reports, and then in our next session, we'll look at the other management related reporting. When you log in as a surveillance officer, you will see the pages menu on the left of the page. When you expand this menu, you will see some submenus. Screenings, prevention, and control submenu holds reports of registered clients, reports of HIV screenings and positivities, reports of syphilis screenings and positivity, and reports of tuberculosis screenings and positivity. And then it also gives you a disaggregation by risk behaviors and key population. So this is what we're going to look at today. For registered client reports, you have a screen that lets you select a year from a drop-down menu of years. This drop-down menu is populated based on all the years that the system finds. So if you have records from 1978, you are going to see all of the years that you have records for on the system. So the system auto-populates these years based on the records you have on the system. Now, when you select a reporting year and you click on Get Data, the system automatically pulls out any data whose year of record or year of report is 2022 because we selected 2022. So it's in real time automatically analyzes and calculates the record. This client registration summary is important because you might have clients who come in for prevention service to a site that does not offer testing, but offers prevention services. And so when those people register a client, and they do prevention and control. They might not have screenings. And so there's now a need to have the registration summary so that we can look at characteristics of the clients that are registered. It consists of 5 tabs that holds different reports. The first one is to look at the sex of the registered clients. And so it gives you a statistics of the total number of clients registered on the system for the reporting year. It tells you the number of female and the number of male clients. It is an interactive chart that gives you when you hover, it gives you a figure when you hover around the plot. But because it is interactive, you can't export an interactive chart. The system automatically gives you below it the same diagram or the same visualization where you can copy or save the image if you want to use the image in this form. The next is the sex ratio of the registration. So it tells you the percentage of females and the percentage of males and the percentage of intersex. And because we have data for just males and females on this trial system, we have the system giving us percentage of female clients who accessed care or who accessed services, and male clients who access services. And then we have that registration distributed by the months of registration. And for each month, it gives us the number of males and the number of females. We also have the comparison of the biological sex and the gender identity of the clients who access services. So we have 4 different category of grouping. We have people whose biological sex are male and the gender identity are male. The people whose biological sex is male and gender identity is female. The people whose biological sex is female and gender identity is male. And the people whose biological sex and gender identity are both females. So this gives you information about the clients you have. And then all of these visualizations have tables, and the system automatically gives you the tables of calculation. In the event you want a different type of plot that is not like this, you can export these tables in CSV, in Excel, in PDF. You can print it out and then use the figures to do your own visualizations if you want to do it in a different way. So this functionality here just gives you the characteristics of the clients based on their personal information and their date of registration. The next we have is now HIV screenings and positivity reports. Again, it asks you to select a reporting year. When you select the year, it automatically generates reports for that year in real time. So this report changes every second as long as new data is entered into the system. So if you get this report today and you need a report in the next 2 weeks, it's advisable to get your reports the day you need it, because if they're using the system in the country, any new data entered will change the figures. If you have 28 screenings today and at the end of today there are 10 new screenings, by the end of today it becomes 38. And it happens in real time. So if you want to get data, the system does not save the state of the record. It calculates it when you ask it to calculate it. So when I select the reporting year, the system automatically generates the data for that year. So every time you generate a data, the figures changes based on the change in data or change in the composition of the data you have on the system. You can only export the state of the data or the state of the report at a particular time. So if I'm taking the record today, I can say this is what the record is as at 9:30 a.m. on 9th of March. By 10 a.m., it might change based on new record entered into the system. Now, once you get the generated report for HIV, we have all of the reporting indicators distributed in tabs, and they are very comprehensive, so you might have to read through every report. The summaries of HIV screening gives you the total number of people screened, including pregnant women, the total number of people screened, excluding the pregnant women, the total number of males screened, the total number of females screened, including pregnant women, and the total number of females screened, excluding pregnant women, the number of intersex clients screened, the number of people who tested positive, excluding pregnant women and including pregnant women, the number of people who tested positive that are males, the number of females that tested positive, excluding pregnant women, the number of intersex that are positive, the number of positive pregnant clients, the number of pregnant clients that have a reactive result to HIV but are not confirmed positive, or that have both reactive and a confirmed positive. And then you get the screenings per 100,000 population with ANC included, and the positives per 100,000 population automatically calculated. And this is where the census population was important, because now the system will use the census population to give you the screenings and positivity per 100,000 population on the system. So you don't need to do any calculation outside of the system. You have it already calculated for you. You now have the visualization of the number of people screened for HIV, disaggregated by the biological sex, and you have the image repeated below for your export. The second tab holds the sex ratio of the people who were screened for HIV. And you can use this to inform yourself of if more females are positive than males. If they're positive because you have more female screening than males, it just gives you an idea of the screening and the positivity of each of the sex of the clients. Then once you get the ratio of screened clients, you can now see the ratio of positive clients. So we still have more females positive than males, which is normal because we have more female screening than males. The system also calculates a 10-year trend in HIV screenings. And if you have records for the last 10 years, it is automatically going to give you the trend like this. If you do not have records for the last 10 years, it will give you just for the current year that you have. Then it also disaggregates this screening by the months of screenings. And then you will see the sex of the screening, both male, female, and intersex. The colors of male, female, and intersex remains consistent throughout the system. So you will know that when you see a blue color, it is talking about the male. If you see the orange, female, and if you see the gray, is intersex. You also have these screenings disaggregated by the age group and the sex of the clients that are screened. And this does not include antenatal. Antenatal reporting is different. So you have the number of males and females screened in the age group 0 to 4. You have 5 to 9, 10 to 14, 25 to 29. And so for as many age groups as you have, up until 60 and over, you will have the system calculate the number of clients by sex screened for this age group. Then it gives you a visualization for the screenings per 100,000 population. So you can, from here, get the female screenings per 100,000 population and the male screenings per 100,000 population. And then the total screenings is the addition of female and male. Then it gives you the new positive summaries, the number of people who were positive in this reporting year of 2022 that we selected. It gives you the positive number of female and the positive number of males. Also, it gives you the same positive clients by their age group and their sex. It gives you the positives per 100,000 population by sex, and also the biological sex versus the gender identity of the clients that are positive. So 5 of them who are positive were male and identify as male, and the females, 3 of them are females and identify as female. So if you have those who are male identify as female or female identify as male, you will have the figures plotted here. It gives you also the 10-year trend in new positives. So if you have data for the last 10 years, it's going to calculate the number of confirmed positive for the last 10 years, and it's going to give you the figures for each of the year. Then it gives you screenings by testing modality, which is a new reporting indicator. And they have definition of test modalities that the countries will define themselves and make sure you can match them with the UNAIDS definitions of test modalities. And then during the screenings, when the user selects the modality of testing, then it automatically calculates the number of screenings for each of the modalities. This does this calculation at the site level and at the national level. It gives you the number of screenings and then the number of persons screened at each site, and then the number of screenings and the number of persons screened on the national level. So the first table tells us, breaks it down by the sites of screening and the different modalities of testing. So you know how many VCT providers did testing at this testing site, and the VCT provider is a government facility. You know how many screenings were done during the first antenatal visit and from each testing site. You know how many confirmatory tests was done and the sites that did the confirmatory test. We also have that for the number of persons screened. So the number of screenings might always be more than the number of persons because one person can have more than one screening done. So you have the number of unique persons screened. So if you want to get the total number of persons that were screened at a site, you can take the numbers here. Now, these same figures are now calculated on a country or national level, where you get the number of persons screened by each modality, regardless of the site. It calculates all of the numbers from each site and gives you a total of the number of people screened. And it also does that for the number of screenings at the national level for each test modality. So when you want to get the number of screenings for testing sites, this is where you come to. The test sites also have their own reporting that are site level. When we looked at the screenings and management, that they can also get their reports without having to go through surveillance. But this automatically, the system automatically calculates screenings done, HIV screenings done at each site and gives you the figures here. Then you want to see the positivity by test modality. So you also see where the people that were positive tested at the sites and were positive, and it gives you the number of persons screened and the number of screenings done. And it also gives you on the site level and on the national level. Then other tables of reports gives you the table of census population that was used to do the calculations. It also gives you the table of screenings done by age group and sex. In the event you need to create a different visualization than what the system generated, you can export your tables to CSV or Excel to have your raw figure, or you can print it out. And you can also get your 10-year trend if you need to change a figure. So let's say in the event where you have one site not using the system and you have this figure and you are sure that the sites here have it, you want to export this to Excel and add the figures from the other sites to recreate your plots, you can do that. You also have, so every visualization done has the table of the aggregated data here for you to export if you want to do something else. Then we have this disaggregation of HIV screenings by ethnicity and also positivity by ethnicity. When you do not enter an ethnicity for a client, it's going to be blank. So these are clients without an ethnicity listed. And then you have the ethnicities of the other clients of people screened. You have the number of screenings done for each ethnicity and the number of positives from each ethnicity. So this is the summary of HIV screenings and positivity that the system generates automatically. So we can take questions before I move to the next functionality.
Essentially, Mildred, from what you showed the first time when you put in the census, which is just male and female, and sex, age, mortality, birth, child mortality. Yeah?
You said?
So the first one that you showed was sex, age, mortality, birth, and child mortality.
Yes.
That's the first one you showed. And then this one, this is under the similar drop down. That's under that one that you're showing us right now is on the similar drop down.
Yes.
Okay.
So the one I showed you was under the administration functionality when you do the configuration. So now we move to the reporting functionalities. So if your role assigned is reporting, then you'll be on this page. But the first one I showed you was for the administration role. So I just wanted to go to that role to see the genesis of the dependent variables and how they are entered into the system before these reports are generated.
All right, so the first one was on the configuration and the second one was on the screening, prevention, and control report. Okay.
Yes. So far, does this answer a lot of your reporting indicators for HIV?
Yeah, I think it does. I think it does. I think it covers almost everything that we're looking to do. Again, it does.
Okay. So we'll look at syphilis screenings and positivity reports, which is very similar to the HIV, only that this time it calculates the syphilis screenings. Now you have the new screening summary, which gives you the number of people screened for syphilis, including pregnant women. Now, syphilis, there are two types of the screenings. It calculates the people screened, regardless of whether it's a confirmatory test or a non-trip test. And then it gives you the positives, which are calculated based on the people who were positive to a confirmatory test, and doesn't matter if they were reactive to a non-trip test. So we have the number of people screened, including pregnant women, and excluding pregnant women, the number of males screened for syphilis, the number of females screened, including pregnant women, and the number of females positive, including pregnant, and the number of males positive, and the number of females positive, excluding pregnant women. Then we have this disaggregated, or we have this, calculated. We have the screenings per 100,000 population with the ANC included, and the positives per 100,000 population calculated. Then we have the visualization, just like we had it in the HIV. Then you have the sex ratio of those who were screened for syphilis, and you have the ratio of the positives for syphilis. The 10-year trend in syphilis screenings, the screenings per month, the screenings per age group and sex for syphilis, the screenings per 100,000 population, the new positive summary. So this gives you the total number of people who were confirmed to have syphilis with a TPPA or TPHA or FTA. It doesn't give you the number of VDRL reactives, but just the confirmed number. Then you have positives by age group and sex. You also have positives per 100,000 population, the biological sex versus gender identity of those who were positive, the 10-year trend in new syphilis positive, and then it gives you the tables where you can export this record, just like we saw in the HIV, and then it gives you the statistics of syphilis screenings and positivity by ethnicity.
So Mildred, a question. I keep hearing you say my 100,000 population. Will it be able to do the calculation similar if it's below 100,000?
Yes. So if your census population is below 100,000, you know the standardized population that is used internationally is 100,000.
Yeah, I know that.
Yeah. So it will still calculate it if it's below 100,000 population. So I will show you in the master trainers training how it is going to present the figures when your population is lower than the 100,000. So you might have more 0.00 something instead of whole numbers. So for this system, when we talk about screenings and positivity, we use per 100,000, but when we go to babies and births, we use per 1,000 population. Then we have the same thing for tuberculosis, screenings and positivity. And so this tuberculosis, when we get to the management reporting, then we'll accurately get the number of people who were MTB positive and the drug resistance testing. But this just shows the number of recorded reactive or positive syphilis test results here, which will not give you the whether it was MTB detected or not. It just gives you positives that are recorded. So it does the same thing it does with the HIV and syphilis by calculating the number of people who were tested, and I'm going to change this description. The number of people who were screened, and including pregnant, excluding pregnant by sex, and 100,000 population. The sex ratio of people who were screened for TB and people who were positive. Since we have no positive, you do not see any diagram here. The 10-year trend in the screenings per month, the screenings per age group and sex, the screenings per 100,000 population, the new positive summary, and since we do not have any positives, it is blank. The positive by age group and sex, which remains blank because there is no recorded positive, per 100,000 population, biological sex versus gender identity of positives. We do not have positives, so we have nothing recorded here. The 10-year trend in new positives has nothing because we have no positive records. Then we have the tables where you can export and the statistics by ethnicity. So here you can see if most of your TB cases are imported or they are from within. So we have looked at HIV, syphilis, TB, and we looked at the basic statistical analysis for the basic reporting for screenings. Now, the system does a disaggregation by key population, but because we want to avoid labels, we use risk behaviors instead of labeling the clients. And so for this, you will look at behavioral reports and prevention statistics. Here, you select the reporting year, and then it gives you reports on the different populations that were screened, the different populations that are positive, and also gives you their access to prevention services for each of these populations. So this gives us HIV screenings by risk behaviors, their life events, and sexuality. So males that have sex with males, the number screened, the number of transgender male, the number of transgender female, the number of homosexuals, the number of bisexual, the number of people who have transactional sex, the number of homeless, incarcerated, people who inject drugs and people who use illicit drugs, and the number of sex workers who were screened within 12 months of the reporting year. So this can give you, if you want to see the access or number of MSMs that were screened or number of sex workers that were screened, this is where you get the figures from. There are other risk behaviors and events that were not captured here. This captures the most important or the most requested reports or the most requested reports for key population. And this gives all of the other different types of risk behaviors, including number of sexual partners and the history of occupational exposure or perinatal exposures. So this repeats the figures for on the previous page, but also adds more types of risks and events. So it gives us the male that have sex with males, people that have sex with sex workers, the number of women that have sex with women, people that have transactional sex, people that have sex with persons of known HIV positive status, people that share needles, people who use illicit drugs, people who have sex under the influence of drugs and alcohol, people who have multiple sexual partners, people who have perinatal exposure to HIV, screenings for people who receive transfusion, occupational exposure, people who were victims of sexual assault, people who received the transplant or artificial insemination, people who are currently homeless or have a history of homelessness, and people who are currently incarcerated or were previously incarcerated, or people who are sex workers or people who have had sex with transgender female. So this gives you all of the people screened. So that when you look at the disaggregation of positives by risk behavior, you can now see which risk behavior or which subpopulation contributes more to the new cases or the positivity. So we want to look at this and we'll see that MSM, inject drugs, people who inject drugs and use illicit drugs are the most prevalent risk behaviors that are positive. We want to look at details of this risk behavior. You will see all other events and risk behavior. And this time it tells you that people with multiple sexual partners are the most positive people in the new cases. And so when you start your campaign or adverts or prevention strategies, you might want to target the population of people who report having sex with multiple sexual partners. Then you want to move to the next, which is perinatal exposure. So you want to tighten up your PMTCT because you see that it's the second highest. Then you move to the key population and injection drug users, and then you move to transgender. So this It's populated based on the hypothetical situation. In your countries, your reports will be different based on the data you have collected, and you will see the most prevalent risk behaviors that contributes to the number of new HIV cases for the selected reporting year. Then you have tables where you can export all of this data that we have seen that gives you all the risk behaviors, the population of people screened from that group, and the number of people who were positive from that group. And you have it in tabs until you have all 21 of the different reports. Then we have reports from prevention services, which gives you the number of MSM that received a defined package of prevention service. And the defined package of prevention service by this system's definition are people who receive pamphlets or condoms or were placed on PrEP or PEP. Then we have sex workers that receive the same. Then we have the number of clients who reported a positive self-test and later confirmed positive by a confirmatory test. And then we have the number of clients on PrEP, regardless of the population, the number of clients on PEP, and the total number of clients on ART. Then we have MSM on PrEP or PEP, sex workers on PrEP or PEP, and then transgender female on PrEP or PEP. And you have all of these figures calculated in an exportable table for you to export and do further analysis. So this is all of the screenings, auto-generated reports for the system. If you notice that anything that you report on is missing, you can let me know. I will take questions, clarifications, and before we close for today.
What about, I guess it will be a lot easier for us to pull out, for example, the number of persons who are enrolled in care because it will already be in the system. But is there a variable that you have directly for that?
To see the number of people enrolled on the system?
Yes. Well, I mean, we're looking at it from a prevention point of view, like, you know, people who come in and get services, but people who are enrolled in your IDC clinic. That's there, yeah?
Yeah, it's there. So that's on that registered client report.
Okay, yeah. All right, good. Wonderful.
Yeah. So you see these ones regardless of screenings, but the people who came in for care, and it's only disaggregates this by their gender identity. So you can have transgender male and female biological sex. So this is just for everyone, regardless of the type of screening that they have assessed. So in our next session, I'm thinking of doing the next session tomorrow, which was on the timetable, but a lot of the people who are supposed to be here are in another training, and I was thinking it might be wiser to cancel tomorrow and have it next week, maybe Friday, so that everybody can be there.
Well, let us know as soon as possible, because again, we also have some training with CMLF. I'm not sure how that's going to turn out. When you get a chance, Mildred, reach out to me, because I need to open probably another account if I'm going to be managing different aspects of that as a test and counselor provider, as a counselor, as a reporting officer, and as a master user. I need to have accounts for all of those things.
Yes, you need to have accounts for all. So, but there are default accounts for all that I will give you, that you don't need to actually have accounts for them, but you use the default accounts.
So, okay, well, we'll talk about it when you get a chance, yeah?
All right. So anybody with questions, clarification, suggestions, or recommendations, if you feel these are not well done, you prefer it in a different way, you can give your opinion, and I will incorporate everything in my development as I round up this project. So I only have between now and Saturday to work on any new recommendations. So if you have them, you can let me know. Even if it's colors, no matter how you think it is not important, just say it. It might just be important.
Hi, Mildred. This is not a question or a suggestion, but it's just a concern. Okay. The training have been quite long, and there's a lot of information. And I guess we will not really get it together until we start practicing. For those of us who haven't started as yet, maybe for those who have started already, it will be a bit easier. But I'm just checking. There are supervisors who's supposed to be over us, but I'm just checking after a time, who is gonna police the police in the sense that to make sure that everything is going well.
So that would be the M&E officers at the OECS who are supposed to be the ones monitoring after this is done. So the program managers will monitor at the country level, and at the OECS level, it will be the M&E officers. My own project or this consultancy ends as soon as the training ends next week, but I will always be there for technical support until the end of the year. In the event you encounter an error or there was something in the design that is not supposed to be in a particular way, I will be there to answer those questions or rectify any error you might have throughout the year. But once the training workshop ends, you will have to revert to the M&E officers at the OECS for any other problem that is not technical support. So I will, based on the participants that are supposed to be here and are in the different training, I will cancel tomorrow and let's have the other parts next week, Friday, where everything will be included, including the antenatal reporting, the EMTCT report, the HIV management, TB management, hepatitis management, and exposed infant management reports. Before that, you can reach out to me if for anything you have seen today, if it's not clear. I'm going to have a comprehensive end user manual for each session. The reason why the manual is not ready before the training is that we were hoping to keep taking recommendations for the training. And when there's a change in design and change in functionalities, I don't want to rewrite the manual. So I want to write the manual after all suggestions have been incorporated into the system.
So how soon so that will be available?
Yes, that will be available at the end of the master trainers training next week. All training manuals and end user manuals will be available for download.
Great.
Any more questions, clarifications?
Nothing from me.
Nothing from me.
Okay. So another question. So far, do you think this is helpful? The reports are helpful, or you think you still need to do other calculations outside of the system?
Well, I think it's reasonably good from what I'm seeing.
Okay. So we'll look at the report of people living with HIV, treatment and mortality. We're going to look at antenatal reporting in details, and we're going to look at the pharmacy reports and stockouts, and we're going to look at TB, HIV co-infection reports. The next session, I will send an email, but I will cancel tomorrow because there is a conflict in 2 workshops going on at the same time.
Okay. It's okay, I guess.
All right.
Okay, Mildred, thanks.
All right. So thank you, everyone. And we are going to see next week. I'll send a follow-up email to the program managers, and we'll most likely have the final part of this on Friday next week.
Okay, wonderful. Bye, everyone.
All right, thanks.
Bye.
Bye.
Okay, bye-bye.